Hi, I'm Dr. DurgaDevi. Today we will discuss some miscellaneous ECG findings and ECG findings in cardiac arrest. So the objective of this presentation is, at the end of the presentation, you should be able to identify ECG changes in miscellaneous conditions like cerebrovascular events, endocrine disorders, pericardial diseases, pulmonary embolism and hypothermia, and also to understand the ECG changes in cardiac arrest. So first I am going to discuss on cerebrovascular events. So what are the ECG changes in CVA? So the possible ECG changes in CVA are prolonged QT interval and arrhythmias, which includes the most common one of them is atrial fibrillation, and other arrhythmias like SVTs and VPCs, APCs can also be seen. Ischemic ECG changes are quite frequent in CVA, which includes T-wave abnormalities. ST elevation can also be seen, which mimics an MI, and ST segment depression, which mimics an ischemia. There can be abnormal U waves, prominent U waves, and sometimes even pathological Q waves, which are rare. LVH with strain is a common finding in CVA patients because many of them have an uncontrolled hypertension. So first I am going to discuss two common ECG changes in CVA. This ECG, the findings in this ECG are, there is an irregular rhythm. The RR interval varies from each beat. Each beat has a different RR interval. The RR interval between each beat is very different, and there are no P waves, and we can see some fibrillatory waves in lead V1, and the ventricular rate is variable. So this one, as you all know, it is atrial fibrillation. Up to 24% of ischemic stroke patients are found to have underlying atrial fibrillation, and in some patients without atrial fibrillation, stroke itself can cause atrial fibrillation due to activation of the sympathetic nervous system. And another common ECG change we find in CVA is something similar to this. This ECG is a normal sinus rhythm. There is a P wave, and each P wave is followed by the QRS. So it is a normal sinus rhythm, and we have prominent S wave in leads V1 to V3 and prominent R waves in lead V4 to V6, which suggests this is a LVH. There is a markedly increased LV voltages. In this ECG, the summation of S wave in V2 and R wave in V6 is more than 35 mm. And there is a LV strain pattern. There is a ST depression with T wave inversion. ST depression with T wave inversion in leads V5, V6 and also in 1 and 2. And there is ST elevation in V1 to V3, and there is a left axis deviation. This is left ventricular hypertrophy. Left ventricular hypertrophy is a common finding because many of the stroke patients have uncontrolled hypertension. So this ECG again is a normal sinus rhythm because each P wave is followed by a QRS complex. So it is a normal sinus rhythm. The rate is around 100 per minute, and we can see the QT interval is very prolonged. The beginning of the Q wave to the end of the T wave is called QT interval, from the beginning of the QRS complex till the end of the T wave or U wave if U wave is present. This is called a QT interval. In this ECG, there is a grossly prolonged QT interval which is almost more than 50%. Almost this is the RR interval. This QT interval is more than 50% of the RR interval. In this ECG, it is almost 80%. Along with that, there is a diffuse T wave inversion. T wave inversion is found in all the leads from lead 1 to 2-3 AVF and V2 to V6. This kind of ECG change is found in almost 30 to 40% of CVA patients, more commonly in patients with raised intracranial pressures. So this ECG, the finding is prolonged QT interval with T wave inversions. So next ECG, In this ECG, what we are finding is a normal sinus rhythm. There is a P wave followed by QRS complex, and each complex has a P wave followed by a QRS complex, and this is a normal sinus rhythm. The important finding, the rate is around 100 per minute. So, the important ECG finding here is T wave inversion in leads V2 to V3 and 2-3 AVF. There is also mild ST depression in inferior leads and in the lateral leads. So, there is widespread T wave inversions with slight ST depression, and the QT is prolonged. QT interval is the beginning of the QRS complex to the end of the T wave. So, this is the QT interval. The RR interval is from the beginning of the beginning of the R to the next R. So, here the QT interval is around 60% of the RR interval. So, QT is prolonged. This ECG is frequently seen in ischemia. So, here in a stroke patient, the ECG is mimicking ischemia. This type of ECG we see frequently in non-ST elevation MI and patients with chest pain with something like Wellen syndrome, where there is a severe blockage in the LAD territory. So, this kind of ECG can be seen in stroke patients. This is another ECG from a stroke patient where you can see diffuse ST elevation. Again, here there is the normal sinus rhythm. There is a P wave and QRS complex, and the rate is around 100 per minute, and each P wave is followed by a QRS complex. So, it is a normal sinus rhythm. There is ST elevation in lead 1, 2, 3 AVF and V2 to V6. So, there is a diffuse ST elevation and there is no significant reciprocal change. There are no ST depressions in this ECG except for mild ST depression in lead AVR and V1. This ECG just mimics a myocardial infarction heart attack, except that if you check, a patient will not have a chest pain, and if you check echo, there will be no regional wall motion abnormality and troponin will be negative. This ECG is but not very common. It is seen in less than 10% of CVA patients. So, this ECG is mimicking a myocardial infarction or a heart attack. This is found in less than 10% of CVA patients. Here is another ECG from a stroke patient. Here you can see the giant T wave inversions with grossly prolonged QT interval. QT interval from the beginning of QRS to the T wave is almost 80% of the RR interval. There is a grossly prolonged QT interval and the T wave inversions are very deep and prominent. This is called cerebral T waves in some places. There can be bradycardia. Here the heart rate is around 60 per minute. This is because of Cushing's reflex due to increased intracranial pressure. This ECG is from a patient with subarachnoid hemorrhage with raised intracranial pressure. Now we are going to see the changes, ECG changes in hypothyroidism. This is a ECG from a hypothyroid patient. Here you can see a P wave here. So, this is a P wave. So, it is a sinus rhythm. So, each QRS is preceded by a P wave. The heart rate is around 30 per minute. The heart rate is 30 per minute. There is a severe bradycardia and the QRS voltages are very low complexes. In limb leads, the QRS complexes are less than 5 millimeter in height. And in precordial leads also it is around 10 millimeter, not more than that. And there are T wave inversions diffusely from V1 to V6. So, this is from a patient with hypothyroidism. Other changes which can be found in hypothyroidism are first degree AV block and interventricular conduction delay. These changes happen due to myxomatous deposits in the myocardium and decreased activity of the sympathetic nervous system. This is from a patient with severe myxedema coma and hypothyroidism. So, what are the ECG changes in hyperthyroidism? This is an ECG from a patient with hyperthyroidism. Tachycardia. This is a sinus tachycardia ECG. Each P wave is followed by a QRS complex and the heart rate is around 200 per minute, something close to or a little less than 200 per minute. So, it is a sinus tachycardia. So, any patient with a ECG with a heart rate of more than ECG and a heart rate of more than 100 per minute, heart rate of more than 100 per minute, you should suspect hyperthyroidism and evaluate for it. So, tachycardia is the important ECG finding in hyperthyroidism. Other ECG findings can be atrial fibrillation, which is quite common, found in around 20% of patients. Other ECG changes can be high left ventricular voltage, like we saw there can be a deep S waves in V1, V2, V3 and a tall R waves in V4, V5, V6, which is not found in this ECG, but this can be seen, but there will be no evidence of LV strain because concentric LVH is not here. And supraventricular arrhythmias like premature atrial beats, paroxysmal SVT, multifocal atrial tachycardia, atrial flutter can also be seen, and VPCs can also be found. What are the ECG changes in pericardial disorders? I am going to only talk about two conditions, okay, acute pericarditis and large pericardial effusion. So, now we are having a ECG. This ECG, what does it show? There is low QRS voltage. In the limb leads, the ECG complexes are less than 5 mm and in the chest leads it is less than 10 mm. So, we are having a low QRS voltage and it is a sinus rhythm. So, what we are seeing is there is also electrical alternance. This beat is bigger, this one is smaller. This one again, this beat is bigger and this one is smaller. This beat is bigger and this one is smaller. So, we are having something called as electrical alternance, where the heart swings backwards and forwards within a large fluid filled pericardium and causing the electrical activity to swing with each beat. So, here we are finding a low QRS voltage, tachycardia. The heart rate is somewhere around 150 per minute. Heart rate is around 150 and there is electrical alternance. So, this is an ECG from a patient with large pericardial effusion. So, the amplitudes of all the QRS complexes in the limb lead should be less than 5 mm or all the chest leads should be less than 10 mm to diagnose as low voltage complexes. So, next ECG that we are going to see now. So, this ECG shows a normal sinus rhythm. Each P wave is followed by a QRS complex. So, it is a normal sinus rhythm. The heart rate is around 100 or around 90 per minute. So, what we are seeing is there is an ST elevation. There is a ST elevation in leads. In all the leads except for AVR and V1, there is ST elevation in lead 2, lead 3, V5, V6. So, there is a widespread concave ST elevation and PR segment depression. In all these leads, if you see, there is a PR segment depression. There is a PR segment depression. There is an ST elevation and PR segment depression. So, how we are saying there is a PR segment depression is by comparing with the TP segment. So, compared to the TP segment, the PR segment is depressed. So, this is a classical finding seen in acute pericarditis. And there is a reciprocal ST depression and PR elevation in leads V1 and AVR. So, this is from a patient with a acute pericarditis. So, what are the ECG changes in hypothermia? This is an ECG from a patient with hypothermia. Of course, in India, we are not going to, at least in Tamil Nadu, we are not going to see hypothermia. But if you work, by any chance happen to work in Himachal or Kashmir, we will be able to see this. This is the J point elevation, which is also known as camel hump or Osborn wave. This ECG, this point is called the J point. The J point elevation, this is called as known as the Osborn wave. So, Osborn wave and hypothermia, I am going to talk a little bit more on this. So what is an Osborn wave? The J point in the ECG is the point where the QRS complex joins the ST segment. The height of the J wave is roughly proportional to the degree of hypothermia. Severe hypothermia, we can find a tall J waves. The J point may deviate from the baseline. J point elevation we find in so many conditions like early repolarization, myocardial ischemia or injury like an heart attack or an unstable angina, pericarditis or bundle branch blocks or ventricular hypertrophies or drugs like digitalis and even in hypercalcemia. And one more thing, if there is a J point elevation with ST elevation in V1, we know Brugada syndrome is diagnosed. So other ECG abnormalities which can be found in hypothermia are sinus bradycardia, supraventricular arrhythmias, QT prolongation and AV block. But out of all this, Osborn wave is the most specific for the diagnosis of hypothermia. Now I am going to deal with another important emergency condition, which is pulmonary embolism, and how to diagnose it with an ECG. Unless you act fast, it is not easy to diagnose and treat a very large pulmonary embolism. So the ECG findings in pulmonary embolism will be sinus tachycardia and markers of RV and RA strain. So sinus tachycardia is the most common abnormality seen in 44% of patients with pulmonary embolism. And because of the right ventricular enlargement and strain, we can have findings like complete RBBB or incomplete RBBB and right ventricular strain pattern. So this is the high specificity. Right ventricular strain pattern is T wave inversions in the right precordial leads. That means in leads V1 to V4 plus or minus the inferior leads, all or at least one of the inferior leads, 2, 3 AVF. This pattern has high specificity. In some studies is found to be 70 to 90% specific for acute pulmonary embolism. It is because associated with a raised, it is even found to be associated with a raised PA pressure. Right axis deviation can be found in 16% of patients. Extreme right axis deviation may occur in some patients. Dominant R wave in V1, again it's a manifestation of the acute right ventricular dilatation. And of course we know this ECG finding S1Q3 T3, very famous. There is a deep S wave in V1 and Q wave in lead 3 and inverted T wave in lead 3. This classic finding, however, is neither sensitive or not specific for pulmonary embolism. Non-specific ST segment and T wave changes including ST elevation and depression can be seen in 50% of patients. Right atrial enlargement, P pulmonale, that means a peaked P wave in more than 2.5 mm, that is more than 2.5 small boxes in height, can be seen in some. There can be a shift of RS transition to V6, which is known as the clockwise rotation, can be seen. Atrial tachyarrhythmias can happen due to RA dilatation like atrial fibrillation, flutter and atrial tachycardia. So now we are going to see few examples of ECGs. What is there in this ECG? Of course, there is sinus tachycardia. Here the heart rate is 150 per minute and it is a sinus tachycardia. There is a P wave followed by QRS, P wave followed by QRS. So it is sinus tachycardia. And this RS R dash pattern is RBBB. This is there is a small R, deep S and R dash. So this is called the left side, this R is more prominent. This is a feature of a benign condition, not a ventricular tachycardia. This is a RBBB. And there are T wave inversions in the right precordial leads. T wave inversion lead V1, V2 and in lead 3. So this sign is very specific. There are T wave inversions in the right precordial leads V1 and V2 as well as lead 3. This sign is very specific for an acute pulmonary embolism. So simultaneous T wave inversions in the inferior and right precordial leads is the most specific ECG finding in favor of pulmonary embolism. That also we are finding in this ECG. And there is so this is from a patient with an acute pulmonary embolism. So next ECG, again in this ECG, we have a tall R wave, dominant R wave in V1. This is because there is a RBBB. Again, this is a sinus rhythm, but here we are not having tachycardia, but there is a dominant R wave and there is RBBB. There is a prolonged QRS complex with RBBB morphology and dominant. There is extreme right axis deviation because you are having dominant QRS complex in AVR and negative complexes in one AVL. This is extreme QRS axis deviation, right axis deviation, and we are having the classic S1 Q3 T3 also. There is a deep S1, deep S wave in lead 1, there is a deep Q wave in lead 3, and there is a T wave inversion in lead 3. So, we have this classic S1 Q3 T3 pattern also in this ECG, and there is a clockwise rotation. That means there are prominent S waves in lead V6. The RS transition is delayed to beyond V6 because of RV dilatation. So, all these findings, and there is a RV strain. There is ST depression with T wave inversion with leads V1 to V4. There are ST depression with T wave inversion in leads V1 to V4, and there are T wave inversion in lead 3. So, this specific sign for pulmonary embolism is also there. So, the diagnosis is acute pulmonary embolism. There is a RBBB, right, dominant R wave in V1, S1 Q3 T3 pattern, and there are simultaneous T wave inversions in right precordial leads and lead 3, and there is a clockwise rotation, extreme right axis deviation, and there is RV strain, that is ST segment depression with T wave inversion in V1 to V4 leads. All this point out to a acute pulmonary embolism. What are the ECG changes in cardiac arrest? So, the next segment of our topic we are reaching there. Cardiac arrest, we have only 4 patterns. Okay, one is ventricular tachycardia, ventricular fibrillation, and one form of ventricular tachycardia is tortuous deep pointers, and these 3 can be shocked and patient can be reverted. This is defibrillation is possible. The other 2 ECG changes are an asystole, which is almost like what we call as flatline, and pulseless electrical activity, where you have an electrical activity but effective cardiac output is not there and pulse cannot be felt. These 2 rhythms, shocking will not help, and we have to start on a CPR, cardiopulmonary resuscitation for this patient. So, these 4 ECG are the possibilities in a patient with cardiac arrest, that is ventricular fibrillation, ventricular tachycardia or tortuous deep pointers, which can be shocked, and the other 2 ECGs, asystole and pulseless electrical activity, where the appropriate diagnosis and treatment of the cardiac arrest has to be undertaken with CPR, okay, simultaneously. So, now let us look a little bit more into this ECG patterns. So, this ECG, what you are finding in this ECG, it is not sinus tachycardia because only QRS complexes. So, what we are seeing is only QRS complexes at a heart rate of around 200 per minute. So, we are not seeing P waves here. So, this is a form of, and all this QRS complex are similar in amplitude and morphology and axis. So, this is monomorphic. This is called monomorphic VT. And the QRS complex duration is more than 200 milliseconds and it has got uniform morphology. This is monomorphic VT. And this beat is a fusion beat. Fusion beat is a combination of the original QRS complex. This is the original QRS complex and the VPC. Together they form the fusion beat. And these are capture beats, that is normal QRS complexes between VPCs. So, this is after reverting to normal sinus rhythm. This is the normal QRS complex in this patient. And Brugada sign is also present in this. What is Brugada sign? So, Brugada sign is a representation of the broadening of the initial QRS complex. So, from the point, so from the beginning of the QRS complex to the end of the S wave. So, this to the nadir of the S wave, that is to the most deepest point of the S wave. If this is more than 100 milliseconds, that means the rhythm is originating and spreading in the myocardium and not in the his Purkinje bundle system. That means there is a scar, and this is most likely to be VT, because the initial QRS complex from the beginning of the Q wave to the nadir of the S wave, that is to the deepmost point of the S wave, if this duration is prolonged, if it is more than 100 milliseconds. So, here it is best seen in VS. Even in V1 and V2, the initial phase of the QRS is slurred. This is a sign that the electrical impulse is starting from the scarred myocardium. So, this is a classical sign of ventricular tachycardia. So, this ECG is a sign of VT. It is important to recognize this ECG, because you will hardly get 2 minutes to resuscitate this patient with a DC shock. So, next ECG we have here is this. What we are finding is, we are finding paced rhythm. There is a electrically paced rhythm. This is an electrically paced rhythm. We can see this pacing spikes. After this, it is followed, the pacing spike is followed by the QRS complexes, but here there is a ST elevation in leads 2, 3 and AVF. That means there is a ST elevation inferior wall MI, and we can even see this Q waves. This could be because of pacing and also could be because of the inferior wall MI, and we are finding simultaneous ST depression in lead 1 and AVL. There is a ST depression in lead 1, reciprocal changes are seen. So, this is a case of inferior wall MI, probably has a complete heart block. So, they have paced this patient. We can find the pacing spikes. So, what happens here is, we are having a ectopic beat here. This is a ectopic beat, and this falls almost at the end of the T. Immediately at the end of the T wave. So, there is a R on T phenomenon, So, this degenerates into a polymorphic VT. So, this is a polymorphic VT. If you see this, the QRS complexes are very fast. The heart rate is more than 300 here, and the QRS complexes are varying in amplitude, morphology and axis. So, they are different. This is a case of polymorphic VT, and this polymorphic VT is ultimately degenerating into a VF. This is a VF, ventricular fibrillation at the end. So, this is also an important thing to recognize, because again we will have 1 to 4 minutes to shock this patient and revert to normal sinus rhythm. So, this is a case of ventricular fibrillation. So, what is in this ECG? This patient did not have pulse. So, but the electrical activity is preserved. There is some electrical activity still present in the ECG. This is a case of recent inferior wall MI, because if you can see, there are ST elevation with T wave inversion in lead 3 and so there is a Q waves in lead 3. There is a Q wave, ST elevation and T wave inversion. So, all this is seen. So, it is a recent inferior wall MI. There is an RBBB. There is a prolongation of QRS. QRS is prolonged. And tall T waves. The T waves are peaked and very tall. Tall T waves are seen in leads, in all the leads. Hyperkalemia. This is because of hyperkalemia. This pulseless electrical activity represents pulseless electrical activity, because the ECG is showing electrical activity, but the patient is not having pulse. It is important to start CPR in this patient, recognize it and start CPR. Along with this, you have to find the cause and correct it. The important causes of pulseless electrical activity are hypovolemia, if the patient is in shock, hypoxia, so we have to ventilate in such situations, acidosis, correction of acidosis with bicarbonate solutions, and hypokalemia or hyperkalemia again can cause this. In hypokalemia, we will have bradycardia, prolongation of QRS, pure interval and all that. In hyperkalemia, we can find tall T waves. Hypoglycemia, checking blood sugars are important. Hypothermia, here it is not hypothermia because we are not finding the Osborn waves. Toxins, poisonings can cause pulseless electrical activity, and other important things are pericardial tamponade, tension pneumothorax. Tension pneumothorax we can find with the absence of expansion with ventilation of a particular lung or so. Cardiac tamponade, here the ECG is not showing low voltage complexes. Echo can help, echo and X-ray can help in the diagnosis, but before that we have to resuscitate the patient. Massive pulmonary embolism, the ECG is not again in favor of massive pulmonary embolism, although there is an RBBB here. An acute myocardial infarction, here in this condition there is acute myocardial infarction along with hyperkalemia. So, this ECG, what you are finding in this ECG? So, this ECG, here we are finding a normal P wave followed by a QRS complex. The first 3 beats are normal, then probably there is and 4 beats are normal. The fifth one is a atrial premature complex, and this falls on the T wave of the previous. There is a prolonged QT interval with prominent U wave. There is a prominent U wave here. This is a U wave. This is a T. This is a T wave. This is a U wave. There is a prominent U wave. Okay. There is a QT prolongation. QT is prolonged. And this APC falls on the R on T phenomenon, almost next to the T wave. So, this degenerates into a polymorphic VT, but what we are seeing is the polymorphic VT seems to rotate around the axis of the QRS. So, it forms like that. The VT seems to rotate along the axis. This is called the torsedis de pointis. Here this patient we are having sinus rhythm is showing inverted T waves, prominent U waves and long QU interval due to severe hypokalemia. And this premature APC is falling on R and T, causing a torsedis de pointis, polymorphic VT or almost a torsedis de pointis. Thank you.